Welcome to the series on covering the latest 2025 ATA management guidelines for adult patients with differentiated thyroid cancer. This is Endo in a Bite, where I break down complex concepts into bite-sized pieces you can actually remember. Let's begin. For differentiated thyroid cancer, surgical strategy is dictated by tumor size and spread. For tumors 2 centimeters or smaller with no gross extrathyroidal extension and no nodal or distant metastases, the preferred operation is a thyroid lobectomy. Removing just the affected lobe minimizes risk, preserves thyroid function, and provides excellent oncologic control. Exceptions include bilateral disease or a suspicious contralateral nodule, in which case total thyroidectomy may be more appropriate. For tumors between 2 and 4 centimeters, lobectomy remains the preferred operation when the disease is unilateral and low risk. Total thyroidectomy can be considered to facilitate radioactive iodine therapy, improve follow-up, or if the patient prefers it after counseling. Importantly, patients must be counseled that lobectomy may need to be converted to total thyroidectomy, either intraoperatively, if aggressive features are found, or later as a completion thyroidectomy. If pathology reveals higher risk disease for tumors larger than 4 centimeters or any tumor with gross extrathyroidal extension or clinically apparent metastasis, the standard is total thyroidectomy. Completion thyroidectomy comes into play when higher risk features are discovered after lobectomy. The rationale is to enable radioactive iodine therapy, improve surveillance, or achieve better local control. This principle applies not just to differentiated thyroid cancer, but across histologies. A less common but distinct entity is thyroglossal duct carcinoma. The initial procedure is a Sistrunk operation which removes the cyst, the tract, and the central portion of the hyoid bone. If there are suspicious thyroid nodules or if the carcinoma is larger, especially in older patients, a Sistrunk plus thyroidectomy may be considered. For advanced disease with gross extension or nodal involvement, a combined Sistrunk and total thyroidectomy is recommended. Completion thyroidectomy after Sistrunk is also reasonable if higher risk features emerge. Lymph node surgery distinguishes prophylactic from therapeutic removal. For most node-negative papillary and follicular cancers, prophylactic central neck lymph node removal is not recommended. It may be considered in more advanced tumors if the information would alter adjuvant therapy or surveillance. Therapeutic, not prophylactic, is the standard unless under very select indications. For patients with thyroid cancer that has spread to the central lymph nodes, we perform a therapeutic central compartment lymph node removal at the same time as the thyroidectomy. In cases where the cancer has spread to the lateral neck lymph nodes, the surgical approach is broader. A therapeutic lateral compartment lymph node removal is performed and is recommended as part of the initial surgery if a biopsy or clinical exam has confirmed involvement. Sometimes a patient has cancer in both the central and lateral compartments. In this scenario, we perform a therapeutic central lymph node removal in addition to the ipsilateral compartment lymph node removal and thyroidectomy. This ensures that all the clinically involved lymph nodes, both in the central and lateral areas, are removed in one comprehensive surgical session. To summarize, lobectomy is sufficient for small, low-risk tumors. Lobectomy is still preferred for mid-sized tumors, though total thyroidectomy is an option. Total thyroidectomy is standard for larger tumors or advanced disease. Thyroglossal duct carcinoma requires at least a Sistrunk procedure with escalation when risk is higher, and lymph node surgery should be prophylactic only in select advanced cases and therapeutic whenever disease is proven. Let me repeat the key points one more time so that they stick. Lobectomy is sufficient for small, low-risk tumors. Lobectomy is still preferred for mid-sized tumors, though total thyroidectomy is an option. Total thyroidectomy is standard for larger tumors or advanced disease. Thyroglossal duct carcinoma requires at least a Sistrunk procedure with escalation when risk is higher, and lymph node surgery should be prophylactic only in select advanced cases and therapeutic whenever disease is proven. Remember, in thyroid cancer, stick to the evidence and avoid overtreatment. And that's it for today's bite-sized episode. A quick, focused review of recommendations 15 to 20. Thanks for tuning in to Easy Endo Prep's Endo in a Bite. Head over to easyendoprep.com to sign up for the weekly newsletter, and pearls will be delivered straight to your inbox. Remember, stay consistent and we'll work through all 84 recommendations together, one bite at a time.